melanoma-specific survival. Do patients who do not receive sentinel lymph node dissection die sooner or die more often than patients who receive sentinel node dissection? And the answer is what? No. They have the same survival. Yeah? There is no therapeutic benefit of sentinel node dissection. Of course, there is prognostic information. We will come to that later. Again, here's a large chart of this. The overall survival was equal between both groups. Does this surprise you? No, because if there is no benefit for elective lymph node dissection, how should there be a benefit for selective lymph node dissection? Because those with a sentinel node positive are only a subgroup of those who were included in the Veronese study, and there was no benefit. So it doesn't really surprise you that there is not a benefit for a subgroup if there is no benefit for the whole group. Now, sentinel node biopsy, the therapeutical concept, does not work. Of course, why does it not work? Because obviously the sentinel node and the lymph nodes are not traps where the melanoma cells don't get out. And obviously it's not this way. Obviously it can be this way too, that there are immediate metastases in inner organs and the lymph nodes are bypassed. For example, and this is from the Morton study, very interesting, you see two groups, all patients, the observation arm and the biopsy arm. And you see here the site of first recurrence, site of metastasis. The observation arm had nodal metastasis in 13% and the biopsy arm only in 4%. But distant metastases were observed in 8% of the observation arm and in the biopsy arm in 11%. So those who had sentinel node biopsies had later more likely lung metastasis, cerebral metastasis, and less likely nodal recurrence. So what do you change with sentinel node biopsy? You only change the pattern of metastasis, but the patients die. Yeah? Here's the difference. Of course, they didn't like that because they are surgeons, and Morton didn't like that because it was his baby. And if this was my baby, and if I would have invented this, I would not have liked this result too. So he did some subgroup analysis, and he was criticized very much for that. I will not go into the details. Obviously, it doesn't work even if you do the subgroup analysis. You can't prevent. You can't say that it works for subgroups when it doesn't work for the whole group. So, but let's assume now for a moment that it would work. Even if it would work, only those would benefit from sentinel node biopsy with a positive node. Those with a negative node would not benefit from this procedure. Only 20% of all patients that where we do a sentinel node will have a positive node. So what do you do when there is a positive sentinel node? Of course, you do then a selective lymph node dissection of the entire lymph node basin. That's what we do, and that's, I think, what you do here also. Now, selective complete lymph node dissection, only 10 to 15% with a positive sentinel node will have subsequent metastases in the other nodes, which also means that 85% of all patients with a sentinel node have unnecessary surgery of the lymph nodes because there are no further metastases in the other lymph nodes. So complete lymph node dissection is unnecessary in 85%, even if you believe in the sentinel node, and it is associated with significant morbidity. Now, what about the morbidity? There's a study also in the GCO, and you see here, it's a busy slide, but you see here the frequency of morbidity of early complete lymph node dissection in comparison to delayed lymph node dissection. But what's more important here, the percentage of lymphedema on the arms, 7.2%, on limbs, 22.7%. So it's not a low rate of complications. It's, I would say, a quite moderate rate of complications for a procedure that in 85% you would not need. Now, does it help? Does selective lymph node dissection help? Or in other words, does it help if you dissect the entire lymph node basin after you have a positive node? So, is it more beneficial if we do it here than if we do it after the sentinel node is positive only? Now, here is a study of that has been published in the Annals of Surgical Oncology in 2010, outcomes of patients with positive sentinel lymph node who did not undergo a complete lymph node dissection. Yeah? So these patients, if the theory is correct, should do worse than those patients who received a complete lymph node dissection afterwards. And why did some patients not have lymph node dissection? Well, there are some. This study had more than 400 patients, and some had not lymph node dissection for various reasons. For example, the patient refused to have it, or the doctor decided not to have it, or other reasons. Now let's compare those who didn't have the selective lymph node dissection with those who did it. And you see the yellow line is those who did not have complete lymph node dissection after a positive node with regard to survival, and the blue line is the line for those who had selective lymph node dissection. And there's no significant difference between the survival, although those who didn't have selective lymph node dissection did a little bit better than those who did not have selective lymph node dissection. So maybe we can say it's beneficial to leave the other lymph nodes because there is also immune response induced by micrometastasis. Why not? This could also be a theory. So does complete lymph node dissection after positive sentinel lymph node biopsy provide any survival benefit? No. So in sum and in short, elective lymph node dissection did not work, sentinel lymph node dissection did not work, selective lymph node dissection did not work, so that the therapeutic concept of sentinel lymph node biopsy is bogus. At least that's my opinion. It doesn't work. Now, what about prognosis? Does the sentinel node biopsy have any prognostic significance? And of course it has. Of course, this here is the progression to melanoma, to metastasis. If you drive from Florence to Vienna and you are already in Venice, you're closer to Vienna than you are in Florence. So if you have nodal metastasis, you are more advanced than if you have a primary tumor only. But that's not a miracle. Of course, and here is the prognostic information, of course those with a positive sentinel node have a worse prognosis than those with a negative node. So the sentinel node biopsy has prognostic information. That's true. And if we do it, we should only do it for that reason and not for therapeutic reasons. Now here is an example of a study where you can see that the sentinel node positive patients do worse than sentinel node negative patients, but this doesn't surprise you. You knew that already. So sentinel selective lymph node dissection, again. Now the question is, if the sentinel node biopsy has prognostic information, should you do selective lymph node biopsy in those patients that are positive? Because this also has prognostic information? Yes, of course, because if you have nodal metastasis in the other lymph nodes, it's even worse as if you have only metastasis in the one sentinel node. So if you do a sentinel node biopsy for prognostic information, it's only consequent to do a selective lymph node dissection if the sentinel node is positive, because this also contains prognostic information. And now I ask you, if you were a patient, would you do selective node dissection after positive sentinel node biopsy? Yes, yes and no. It would be only consequent to have to receive this as prognostic information, but would this be enough for you? Would you perform a complete lymph node dissection only to obtain a prognostic information that may be completely useless for an individual person? Because what does it mean to you if you can say you have a 30% higher chance to survive 5 years than those?